Hi, everyone. I am Rachel Warner, the Executive Director of the Leonard Davis Institute at the University of Pennsylvania. Welcome to today's seminar on value-based payment. Thank you all so much for being here. There was a lot of interest in this topic, with over 800 people registering for today's event, and many of you submitted questions in advance, so thank you for that interest. Value-based payment has been a central strategy to reforming healthcare since the passage of the Affordable Care Act. Traditionally, healthcare has been reimbursed using a fee-for-service system based on the volume or the intensity of care provided. So the more you do, the more you get paid. Value-based payment changes that paradigm, and instead it links payment to patient quality and outcomes, focusing on constraining the use of unnecessary healthcare and slowing the growth of healthcare spending. There's been a lot of enthusiasm for this approach, in part due to its face validity. It seems obvious that it should work. And in fact, in 2015, the federal government committed to tying at least 90% of traditional Medicare payments to quality by 2018. They also committed to have at least half of payments flowing through alternative payment models by 2018, where alternative payment models are a type of value-based payment that hold providers financially accountable for both the quality and cost of care delivered to patients, rather than just adding bonuses or penalties to existing payments. APMs include things like accountable care organizations, bundled payments for episodes of care, models like the comprehensive primary care model, and other arrangements. So while CMS met its goal of successfully tying 90% of payments to value, it has fallen a little short of its goal of 50% of its payments through APMs. And so one of the questions we're left with is, has value-based purchasing achieved its goal of curtailing healthcare spending while also improving quality? And I think many people would say the goal has remained elusive, even with APMs, which offer more promise. There have been some notable successes, along with models that have struggled to deliver meaningful savings or quality gains. I want to do a little bit of level setting before we get started today to give us a fact base about what the research has generally shown to date. So starting with what has worked, I would characterize these as real but sometimes modest wins. First, the Medicare Shared Savings Program, which is an ACO, and it's Medicare's largest value-based payment program. Research on this has found that physician-led ACOs have performed best, and there's been some savings to Medicare. Over the period of 2012 to 2019, there was an estimated $4.1 to $8.1 billion saved by Medicare. In addition, there was no evidence that it harmed quality. Bundled payments for procedural episodes are another area where there's been some wins, particularly for lower extremity joint replacement, which is Medicare's largest bundled payment model, and it is also a mandatory model. There's been about 2.7% reduction in episode spending, again, without any harms to quality. And overall, the growth on healthcare spending has flattened somewhat, and some people have pointed to value-based payment as one of the reasons for that change. So those are some of the wins, but the promise has also fallen short. Regarding the growth of healthcare spending, healthcare costs have continued to rise, particularly with recent upticks, and the US spends significantly more on healthcare, both per capita and as a percentage of the GDP, than other high-income countries. Additionally, some of the savings in successful models may have been driven by favorable patient selection. So ACOs have ended up treating less costly populations rather than reducing costs. Models that target high-cost populations, such as those with end-stage renal disease, have generated savings in part due to selecting lower-risk patients. There have been some unintended and negative consequences in some programs. For example, the Hospital Readmission Reduction Program did successfully cut readmissions to hospitals, but at least one JAMA study found that it increased mortality rates after discharge. Some programs have shown no real effects on quality, such as MIPS, which is a pay-for-performance program for physicians. And with some exceptions, value-based payment has largely not improved access to care or health outcomes for populations with social risk factors, including racial and ethnic minorities, rural population, and individuals with disabilities. Meanwhile, payers focus on value has catalyzed a growth of a group of corporate intermediaries. So where does that leave us now? As the Trump administration sets new health policy priorities, some have argued that the focus of value-based payment distracts from addressing the true drivers of high healthcare costs, and that it is time to move on and return to an improved Medicare fee-for-service system. The experts we have with us today will help us weigh the pros and cons of value-based payment and its alternatives. So we are joined by two great experts in value-based payment. First, Farzad Mastashari is the co-founder and CEO of Aledade, which helps independent primary care practices succeed in physician-led ACOs. He formerly served as a national coordinator for health IT in the U.S. Department of Health and Human Services. And we are also joined by Andy Ryan, who is the Provost Professor of Health Services Policy and Practice at Brown School of Public Health, where he also directs the Center for Advancing Health Policy through Research. And his research focuses on understanding and evaluate the effects of payment reform and healthcare reform. So I'm going to start by asking each of you to react to the summary that I just gave you about what is known to date about value-based payment. I tried to stick to the main facts, but I may have missed pieces that you both think are important, and so would love to hear that. And as I'm sure we can agree, we can each look at the same information and come to different conclusions. So we invited you here today in part because I know that you have some differing opinions about the promise and perils of value-based payment. So Farzad, I might start with you. What have we learned about value-based payment to date, and what did I leave out of my summary?
Thanks so much, and really happy to be joining you and Andy for this important discussion, and really pleased to see the participants. And scanning through the list, there's some folks here who very well could also be sitting here and helping guide the discussion. I think let me just start with value-based care. You mentioned a lot of things as examples of value-based care, including MIPS, which is really, I think, part of the challenge we have in having a discussion around this. And my preferred definition of value-based care is, and generally, like, tell me how you're paid. I'll tell you, what your incentives are, and therefore, like, how you're going to act, right? And I think, to me, a clarifying definition of value-based care, you're really doing value-based care if you make more money if someone does not have a stroke versus if they do have a stroke, right? So, by that definition, much of what we have seen is, kind of the label of value-based care put on basically fee-for-service with a fig leaf. Let me maybe, if I may, just a brief history of my personal history on that I hope will be illuminating. I spent 10 years at the New York City Health Department, and our goal was, as I was in a public health department, a city health department, and our goal was, how do we save the most lives? And that was obviously tobacco from a public health perspective, and from a clinical perspective, we ran the numbers any which way, and it's blood pressure control, right? So the answer to the question, how does medicine save the most lives, is blood pressure control. And yet we had it under control about 65% of the time. And so you got to wonder, like, we have a $4 trillion then, $5 trillion now healthcare system, and the thing that would save the most lives, we're not doing. And why aren't we doing it? And I thought, well, it's the information systems. This is back in 2002. We don't have information systems, we don't have workflows, and we don't have payment to support it. And I thought the key to the whole thing was the information systems. And I spent the next 10 years of my life, and you mentioned, including as U.S. National Coordinator for Health IT, getting us to a place where we went from 20% of doctors having EHRs to 80% having EHRs. And blood pressure control didn't improve at all. And that technology got used, guess what? For billing, for billing fee-for-service, right? So the technology gets used not to transform the business case, but in service to the business case. So then what is the business case? And you mentioned, in a fee-for-service world, it's around volume, but it's also around market power. The reason why, picking on you for a sec here, the reason why Penn, right, gets paid a lot of money and is in, big time player in fee for service is because you can tell a health plan, you got to pay me more than that community-based primary care doc, right? And if you're paid 2 times, 3 times, 4 times what someone in the community is, you can then afford to buy or tie up the primary care practices and steer the MRIs and the specialist visits and the admissions to the mothership. That is what is driving healthcare costs, is not only the perversity of the incentives, but also the self-reinforcing aspect, which I suspect Andy's going to, I hope, agree with me, is consolidation in healthcare and lack of competition in healthcare. And so when I started Alidate 11 years ago, I was like, well, how do we find a business model somewhere in healthcare where preventing strokes is going to be more profitable? That's what I can wake up in the morning thinking, how do we keep people healthy and out of the hospital? And for me, the answer to that was when I first saw the first reg for the accountable care organizations. And I was like, this is mind blowing. You get a group of primary care docs together, you take accountability for the total cost of care for their patients. And if you can bend the cost curve, and I believe that primary care and prevention, better coordination, better chronic disease management, yes, better blood pressure control can reduce downstream costs, you get to keep half of it at that time. Now 75% of it, hopefully one day 100% of it, right? That's mind-blowing. That is completely flipping the polarity. And I went into this convinced that it wasn't going to be hospitals. And that's what the data has now shown. You mentioned it, right? Physician-led, primary care focused, low revenue. I love that. Low revenue ACOs are the ones that are more successful at actually getting after reducing hospitalizations. And we are. And it's also really hard to motivate specialists who are making a lot of money in the current system without there being some involuntary program to kind of embrace this completely new business model where they're doing pretty well by their existing business model. But primary care, particularly independent primary care, is not doing well. And I think value-based care is one of the few places where, and in particular, I think we're seeing in ACOs where primary care gets accountability for total cost of care and using the influence they have can discipline downstream care, can improve health, can keep people out of the hospital, is absolutely showing value. So I would say there's a lot of things that have not worked, but the thing that has worked is give primary care accountability for total cost of care. And I can go into more of the details as I'm sure the dialogue here continues. But the Medicare Shared Savings Program is really the crown jewel of value-based care right now. 11 million people, as you mentioned, seniors out of 28 in traditional Medicare in that program. Alidate is the largest participant in that program through all of the 47 states practices, independent practices, and those come together. We support them. We provide them with the tools, the coaching, the playbook, and the financial backing to be able to do this at scale. And we were 11% of the Medicare Shared Savings Program and 19% of the savings in that program. We're going to be sending the last of $400 million of payments to community primary care-based practices in the next week. So I'm very proud of the work we're doing, and we're still tiny. And so I think the question here should be really, I think the heart of the problem is how do we grow both participation in the Medicare Shared Savings Program and also the incentives to get higher savings rates in the program.
Okay. So that was one vote in favor of value-based payments.
Shocker.
Andy, do you want to respond to where are we with value-based payment?
Well, thank you so much, Rachel. So let me start by just kind of reiterating several points you made from the introduction that since the passage of the ACA 15 years ago, that value-based payment has really become the focal point as a strategy to reduce spending growth in Medicare and enhance value. And well, there's a lot of different flavors, as you mentioned. I think the feature that's engendered the most enthusiasm from policymakers has to be risk contracting, where providers are responsible for the total cost of care that is borne by Medicare beneficiaries. You refer this to APM. I'm just going to refer to this as risk contracting. And then agree that the Medicare Shared Savings Program is the exemplar program here. And so, again, just to like level set, these programs were designed to reduce spending growth to bend the cost curve, and they have not worked. They have not achieved that goal. They're not bending the cost curve. And frankly, I'm going to go further and argue that due to some critical conceptual and theoretical flaws, they can't bend the cost curve and are imposing significant costs on the system. And we need a fundamentally different approach to address what I view as an affordability crisis in the United States that moves away from risk-based contracting. So let me talk about some of the evidence, Rachel. So, I'm going to start with the Medicare Shared Savings Program because, this has been, the flagship program in Medicare. And so some of the earliest evidence suggested some modest savings in the program, about 1% in gross spending. But subsequent research highlights a couple key unintended consequences related to both upcoding and selection. And once you account for those two kind of strategic gaming behaviors, the estimates of savings declines to basically zero. In addition, the erroneous incentive payments that participants have achieved through the selection and upcoding has inflated Medicare spending. So instead of saving money, this is actually, my view is that this is increased spending for the Medicare program, and that much of these inflated payments from selection and upcoding has been kind of abetted by middlemen like Aledade and other convener firms that have helped participants to kind of strategically game benchmarks. And it's not just the Medicare Shared Savings Program. CBO did a review and found writ large that the portfolio of value programs in Medicare was increasing spending by several $billions. So it's not a huge budget effect of itself, but it's still increasing spending rather than decreasing it. Now, as you mentioned at the outset, Rachel, some people have argued that, well, we shouldn't be looking at these individual program evaluations. Instead, we should think kind of writ large about what's happened in the community. And they kind of, as you mentioned, point to this like reduction in spending growth that happened around the time of the ACA and say like, well, there's this kind of like vibe shift around value that kind of led providers to be more efficient. And this is, proponents have called this the zeitgeist theory of value. But this, to me, doesn't hold up to empirical scrutiny at all for several reasons. Number one, that spending growth in the United States began to decline in 2005, which was years before the value program started. Number one. Number two, that spending growth occurred throughout OECD countries. It wasn't just a US phenomenon. It occurred in places that had no VBP exposure. I think number three, that the reductions in spending growth were empirically related to slowdowns in technology adoption. And then number four, as you mentioned, that there's been an uptick in spending recently in the United States as value-based payment and risk contracts have continued to expand. So to me, this falsifies the zeitgeist theory. I'm going to make a couple conceptual points too that I think like if we my take that I'm going to argue today is it's this fundamentally the coverage and pricing policies in Medicare that are driving spending growth, and that risk-based contracts and ACOs are either don't have the incentives to address spending growth due to technology adoption, or they don't have the capability to do it. And so they're fundamentally misaligned to address the core spending problems that we have, number one. And number two, I'll say that the way that targets get set in the program is based on spending in traditional Medicare. So you think about some new low value technology coming into Medicare, like skin substitutes or something on the Part B, physician administered drugs, that's going to increase traditional Medicare spending. It's going to straightforwardly increase benchmarks in ACO. So the spending growth is going to be determined based on what happens in traditional Medicare. ACOs are just going to follow along. And honestly, whenever they've been asked to reduce spending growth, more than what would happen in traditional Medicare, they complain about ratchet effects and how it's not fair and they can't do that, which basically admits that they're not able to address the reduced spending growth over the medium term. One other thing I want to say, Rachel, is I think that value-based payment programs have impose significant costs on the system. And a couple I want to highlight have to do with consolidation and administrative burden. And so you think about what these programs are asking providers to do. It's asking them to take on different insurance functions like risk management, like setting up networks, like figuring out how to upcode. And these are things that providers in general are not oriented towards doing. So they have a couple options. They can join with larger entities and fuel the kind of consolidation that Farzad mentioned has been highly problematic for our system for a number of reasons. That's one option. Another option is to build that administrative capacity themselves, which in a straightforward way is including increasing administrative costs. Or they can partner with middlemen like Aledade, who, team up with participants, they help them game the program rules, and they take a cut of the savings. And so just by virtue of the fact that the programs aren't working to reduce spending overall and are increasing administrative costs, I just view that as basically waste. So just to summarize, Rachel, these programs haven't worked. And by design, I don't think they can work. And they're imposing significant costs. The last cost I will say is related to opportunity costs. It's like we've been going down this road of value-based payment for 15 years, kind of putting our eggs in that basket. And I think like we've avoided addressing these key cost drivers by searching for these kind of elusive win-wins in value-based payment. And I think we really need to reckon with the fact that risk-based contracts aren't going to get to where we need to go. And we need a fundamentally different approach to address what I think is a central public policy issue around healthcare affordability in the United States.
Thanks, Andy. I want to invite both of you to jump in and respond to each other if you want to. And we have the hour is going to go by quickly. And so happy to have you guys jump in. And Farzad, I don't know if you want to respond. Go ahead.
I sure do. Yeah, I think what it's a pretty what's elusive is the evidence from a scientific perspective to back up the pretty, I thought, the charge that the savings in the Medicare Shared Savings Program are a result of gaming. And the evidence that Andy is, I think, citing, or at least was cited in his recent article, is an analysis that he himself did based on previous work by Mike McWilliams, who disagrees that selection effects and upcoding are major drivers. And I think there was a retraction of an earlier paper that seemed to imply his views and that paper's views differently. And what you did in that paper, I think, was pretty questionable in terms of your assumptions around, let's take static, the savings estimate from the early years of the program, and then let's just add in the payouts without assuming that there's been zero increase in cumulative savings over the time frame of the program, which is just strange methodologically, Andy. So I would say if you're going to bring that sort of claim that the savings in this program are entirely due to upcoding and selection, you need to bring a little more stronger evidence and better methods. I'll give you one example that you could easily have examined, which I think would solve both issues, which is to look at trends within year. Look at practices who are in the Medicare Shared Savings Program in, for example, a high trend year like 2024 that we just had. Those patients' risk codes can't change during the year. They are assigned based on last year's diagnoses, so it's not an upcoding issue. And the practices, the TINs in the program, once you start the year, they're the ones in the program. You can't drop the TINs. Those are those who are in the program. And in 2024, again, something that you easily could verify yourself, should you choose to, if you're actually interested in getting at what is happening in the program, is it all upcoding and selection? you would find that in the traditional Medicare population, of the 11 million patients who are in that program, who are in the Medicare Shared Savings Program, trend was about 6.8%. And in those who were not in the program, it is almost 10%. So here we have an example of ACO participants bending trend by 300 plus points within a year, which cannot be done, cannot possibly be explained by either upcoding or selection effects. So I think it's just a very disappointing, I guess I would say, for that sort of the sort of assertiveness with which you make a claim that is, I think, a pretty serious claim that could be examined. And I think the consensus of the scientific literature is not what you represented it to be. Let me also say, to answer your question around what are the folks doing, and most of the ACOs that I know of, and certainly the ones that we work with, our focus is on access to primary care. Number one, getting access to primary care is one of the hardest things in today's world. And our best performing ACO in Louisiana, which had 0% savings received the first 3 years of the program, right? Which you said, like, they had modest savings in the first few years. They didn't have any savings the first 3 years of the program. We worked on blood pressure control. We worked on access. We worked on care coordination. We worked on care transitions. And they are now the top savings in the Aledade universe, 17% savings rate. They were ranked number one of 400 ACOs for access to primary care and coordination of care by the patients surveyed. Patients themselves reported extremely high levels of access to their docs and coordination of care. That is what is driving the savings. Otherwise, would be hard pressed to explain why should a program that is lemon dropping high-risk patients, why would patients say that they have really good access to care? Why would they say that they have great coordination of care? So the other thing that you would be hard pressed to explain is why blood pressure control, I'm going to come back to blood pressure control because it's the single biggest driver of premature deaths in this country that are preventable, is significantly better in the Medicare Shared Savings Program. Not just that there's no harm to quality, but CMS has clearly reported that not only is blood pressure control as the signal quality measure much better in the Medicare Shared Savings Program than in MIPS-landia, but it's also improving faster. So going from 78% to 80%. Aledade is 84%. Okay, and we have community health centers in the Mississippi Delta who are surpassing the national average significantly. And so you tell me why that is selection effects and risk coding leading to better blood pressure control, Andy.
Yeah, that's great. No, I'm happy to talk about the evidence. So first of all, our own research has found that there's selective exit from ACOs and a combination of higher spending, TINs, MPIs, and bennies all exit attribution higher rates. So that's one thing. MedPAC themselves showed that through that there's like selective attribution that happens through wellness visits where ACOs go out and try to find the healthier bennies to attribute and avoid the sicker bennies, like the people in SNFs, which is why CMS had to close that loophole because they were gaming. I think what's really interesting, if you look closely at the recent Cornell study that Rachel mentioned at the outset, what's fascinating is the extent to which the effects that they observe, that they interpret as real savings, are actually driven by selection and upcoding. So a couple things to note is, like, if you look at their just like unadjusted spending, change in spending for ACOs and non-ACOs, it's quite modest, actually. It's something on the order of like $60 per member per year over the first 3 years. And so, and what's also interesting, if you look in their appendix, you see that sicker patients, people who are disabled, people with ESRD, racial and ethnic minorities, are more likely to exit from the program, to not be attributed as the program goes on. So you see clear evidence of selection on observables. And while the ACO populations are getting healthier, you actually see increases in risk coding. So HCC scores increase. So basically, you see this phenomenon of favorable selection and upcoding, which this is what happens in risk models. This is exactly what we see in MA, and it's been very well documented. And it's the exact same phenomena that's happening in the Medicare shared savings program. So,
Can I?
this is the nature of the evidence here. And so the other part I'll mention about selection is if you actually look at what these ACOs are like, ACO is supposed to be a virtual delivery system, providers kind of like coordinating, sharing information, jointly managing patients. And what people don't understand is the extent to which these ACOs are like literally often dispersed across states, across regions, across the entire country in a single ACO. And so this behavior has increased substantially after regional benchmarks, which enable the strategic selection of TINs in order to beat a regional benchmark. So this is basically the strategy that middlemen conveners like Aledade take to beat benchmarks, and then under the auspices of supporting primary care docs. I mean, what I'll say about that is it's
Can
like,
I? Can I just? I think. Can I just before we get too far past a few of the points you made, Andy? So you mentioned the selection effects and MedPAC, and I chuckle because there's a difference between people who've actually been doing this work and the understanding of what happens and why versus folks who perhaps are looking at observations and then stringing them together. So MedPAC and MedPAC's point was there seems to be more annual wellness visits later in the year. And I'll tell you the reason for that is because when you first sign practices up to an ACO, you're signing them up in the summer. And then what we can do is we can try to begin the process as soon as possible of having a preventive visit that puts your arm around the patient. And let me just say, again, you're completely not fact-based in saying annual wellness visits are prioritizing the well. Annual wellness visits are prioritizing those who have the biggest chronic burden. Those are the
it's
people
weird why they don't
literally,
have it happen for patients with
I'm
Smith
just
visits.
saying,
It's just kind of weird.
literally, that is our sort order, is start with the sickest patients. Put your arms around the sickest patients. Okay. So you don't, I think
That's not what the
if
MedPAC
you would like,
report shows.
no, what the MedPAC report shows is that there is more annual wellness visits later in the year. And they are assuming, putting dots together, they assumed in that there's some master plan where you go out and you hand pick, I want this patient, and then you do an annual wellness. The reason why they're stacked in the fourth quarter is you have to put 11 months between annual wellness visits. So once you push more annual wellness visits in your first year, you then have a schedule where they get backloaded year after year after year. And again, you want to talk MedPAC, I don't think Chernew agrees with you that this is selection effects and upcoding. And I think there's a
No,
lot of there's a lot
no.
of pattern matching that you're doing and saying this is like MA. Whereas in the Medicare Shared Savings Program, you should also mention that for the first 8 years of the program, there was zero benefit to increasing the risk score. In fact, we are losing ground compared to traditional Medicare on the risk scores. And if you actually look at the data for what the average risk scores are for ACOs versus non-ACOs, it's darn near close to 1.00. So
Okay,
I
I'm
don't think
gonna
there's evidence that there's risk coding. I don't think there's evidence that there's upcoding. And I want to get to the heart of the issue, right? Which is this program, it's like you're saying solar energy hasn't solved climate change, And so the problem that we should really all be focusing on is solar energy, right? Whereas like you could aim it at, you want to aim something at upcoding and selection, you could look at Medicare Advantage. Why are you saying, like, of all the places in the world where we have to identify like what the problem was, it's the Medicare Shared Savings Program. Whereas like you want to look at upcoding and selection effects. Any dollar saved, let me actually, Milliman did the study. I think I'd love to have you answer this one. Milliman did the study. A 1% increase in risk scores in the Medicare Shared Savings Program would have a 9-to-1 savings to the government on reducing overpayment to MA.
Okay, well, I mean, I don't know what you're
So
saying
Andy,
there.
I'm going to just jump in briefly. Farzad asked you a specific question. Just if you can answer briefly, because then I have a question. I mean, moderator's prerogative. I'm going to ask the next question.
I'm sorry, Rachel. So are
Yeah,
are you
I'm
asking me
saying
a
you can go
question now?
ahead, but just to keep it brief.
Oh, okay. Well, just let me just take the MA thing. Like I agree that there's tons of upcoding and selection in MA, and looking at it and just take a bite out of it. I guess my point is it's a generalized phenomena for risk contracting, and this is how you get ahead in risk contracting. This is like it's hard to do all the management stuff. You said it's a lot easier to do selection and upcoding, and this is why, like, I have such a lack of one of the reasons why, I just don't have enthusiasm for this as a cost control strategy. And in so many ways, the incentives are stronger to do the exact same things that, the incentives are for in the MSSP. It's the same incentives, only stronger in MA. And, MA in many ways has so many more distortions that MSSP has. And if you're saying like, oh, the solution to addressing upcoding in MA is to do upcoding in MSSP, I think that's kind of hopeless. And instead, we should be looking at something that isn't just administrative shenanigans, and is actually addressing real spending growth in the country.
Okay, so Andy, I want to change the topic slightly and turn to what alternatives might be. And so you've laid out your arguments about why you think value-based purchasing may not be the right path forward and what some of the downsides have been. I'd love to hear from you the alternative path that you have outlined previously.
Yeah, no, absolutely. So I think that, my view here, Rachel, is that fee for service has been unfairly villainized, and that it's the problem isn't fee for service per se, but how it's been implemented in the program, in the Medicare program. And the real solution is to address the coverage and pricing problems that exists in Medicare. And just to give just like some high level thoughts on this, as you think about like how coverage works in the Medicare program, just focus on drugs for a minute, that basically once the FDA approves a drug, it automatically goes on the Medicare fee schedule. And famously, Medicare isn't able to negotiate prices outside of a handful of drugs. And so as a result, we have routinely have new oncology drugs, for instance, that enter the fee schedule costing more than $100,000 a year with very little benefit. And so this is something that is a huge driver of spending. And because CMS, Medicare doesn't have the explicit authority to consider cost effectiveness for coverage, it's not just a drug issue. This is the exact same problem on the fee schedule side, where the criteria for Medicare coverage is only that a procedure is reasonable and necessary. There's no cost of effectiveness criteria. And then the specialty societies and the AMA have undue influence in deciding what the codes are. There's 10,000 codes and how they get valued. And it's through this interaction between lax coverage policy and misvalued codes that we have this cycle of low value technology ending up on the fee schedule. And this is what's driving spending. And this is what risk contracts are absolutely unable to address. And so, I think one example I'll just give is the skin substitutes. This is something that came on the Part B fee schedule that was overused to a great extent because of how it was incentivized and mispriced in Part B. It inflated spending. And then the fix to this problem, it wasn't to do risk contracts around skin substitutes. It was to fix the pricing distortion that was inherent in Part B. Okay. And so this is my main point, is that through VBP, we've jumped ahead to these quasi budget ideas while not addressing the fundamental problems in the fee schedule and the pricing issues. And so until we do those things, the budgets are pointless, frankly. And so like once, personally, I'll say, like, if we are able to rationalize coverage decisions and rationalize our fee schedule, and then we want to move towards hospital budgets and maybe save a little bit more, like, that's fine. Like, I'm good with that. But until we, address this first order problem, which has been identified going back to Newhouse and Weisbrod in the 1990s, of technology and the interaction between new technology and prices driving spending growth, until Medicare addresses that directly, instead of trying to kind of outsource it to like middlemen, we're not going to get anywhere on the problem. So this is, I guess, the fundamental issue, Rachel, is prioritizing these coverage and pricing decisions within the Medicare program.
Yeah.
And I would
Before,
say,
before I let you jump in, I
before I
promise I'll let
agree,
you jump in. I want to ask Andy one follow-up question, which was something that came in through the chat, which was that maybe, and this is related, if you'll bear with me. The question is whether or not bending the cost curve is the wrong goal for VBP, and should we want spending to increase if it pays for higher value care. No one knows how much value there might be from technological changes like anti-TNFs, Wegovy, et cetera. And so do you want to just comment on sort of how you think about new and expensive therapeutics and how that fits into this?
Yeah, absolutely. So now I think that in general, we would be a lot more accepting of our high spending if we thought we're getting tons of value from it, frankly. But that's just not, I think there's this like widespread idea that we pay for a lot of low value things at inflated prices. And that's the problem. So like, I agree with that question. And GLP-1s, frankly, are an example of expensive technology that I think is high value and that we should pay for. So, the bending the cost curve is kind of a shorthand for reducing spending growth, shifting towards higher value care, which is like fundamentally why it's a cost effectiveness criteria that we should be considering in coverage decisions that have become verboten in Medicare, which is like a huge, this is like our huge problem, is like things end up on the fee schedule, things end up in Part D that just like aren't cost effective. They inflate costs without making people better off. So, by being more intentional about deciding what we pay for, then I think we would all be happy if spending is increasing on things that are legitimately making people better off. But that's just unfortunately not the case.
Okay, Farzad, to you.
I wanted to agree with Andy that there are real opportunities, including on the fee schedule that he mentioned. I'll just say, like, again, like it's like saying the nature of this debate, right? It's like saying, until we have whatever price on carbon, solar energy is the problem, and the contention of like spending all of the effort on disproving supposedly like the one thing that actually seems to be giving patients more access, higher quality, more coordination, giving primary care doctors who are vastly underpaid in the fee schedule more resources, and reducing trend for society. It's like that's the problem. And I just like, look, you mentioned skin substitutes. You know who's really, who was really in favor of fixing skin substitutes? You know who's actually submitted the comments to CMS in support of the skin substitutes? Was the ACO community. You know who identified the skin substitutes and brought them to CMS's attention? The ACO community. Why? Because we're aligned finally with the cost control, as opposed to what I think you're suggesting is an endless series of really important tweaks to fee for service. And I think you just like, I want to just understand what you're saying here. At the end of the day, you think the right way to pay for healthcare is fee for service, right? Like you wait until people have a stroke and then you pay for the stroke. And how do you improve quality, Andy? How do you propose to get people to care about not having strokes with fee for service? I want to hear that.
Yeah, I'm going to talk about the skin substitutes thing first, because I don't think the ACO people understand how much this point undermines their central argument that basically the solution to the skin substitute issue is fixing the fee schedule. It's not putting providers at risk for the
That's not
spending.
what I said. That's not
I
what I
know it's
said.
not what
I
you
said we
said.
identified. I
I
said we identified it
and the
and we
fact
raised
that
it and we asked CMS to
honestly,
fix
the
it.
fact that you identified it, it speaks to the lack of capacity and orientation that CMS has towards managing its own fee schedule. That should be first order issue at Medicare and CMS. And they've taken a remarkably lax, laissez-faire approach to managing its own fee schedule. And like that is, it's frankly a governance issue that so much of what CMS should be doing has been outsourced to intermediaries to manage, which is absurd. And like, it's nice that the ACOs picked it up, but the answer is not to make ACOs the fraud detector. And it's not to put them at risk for fraudulent spending from skin substitutes. It's to fix the fee schedule. That's the key point here. And it's like the risk-based people have just put the cart before the horse and said, like, we can have this crazy, disoriented, like dysfunctional fee schedule and just stick some quasi budget concepts on top, and that's going to fix things. It is not. I also want to address this issue around physician ACOs, and frankly, have such limited ability to address anything that happens in specialty care, in hospital care. Like, and this is where all the so much of the low value technology adoption happens. So even if physician-led ACOs, primary care ACOs, they want to, reduce spending out there, they don't have the tools to do it. They don't have the capability to do it. So this is like this fundamental mismatch between incentive and capability, which is why we can't give responsibility for cost control to the set. I mean, it's frankly absurd to say like, oh, Medicare, the agency that sets all the rules, we're not going to actually use the power we have. We're not going to let Congress, have Congress give Medicare the power they have to control prices and manage coverage decisions. Instead, we're going to focus on outsourcing that to a bunch of like physician practices to manage cost control. It's ridiculous. It's totally ridiculous. And one other thing I'll say, it's a matter of some people, I think a lot of people say, oh yeah, we should fix the fee schedule. We should fix the fee schedule. But all the attention and effort and priorities has gone towards risk-based contracting. Like that's where the policy discussion has been. And this is like a key point. Like all the stuff that's happened here in MSSP, like I think has made the system like marginally worse, but not a lot worse. The biggest problem has been the opportunity cost, that we haven't made any headway towards solving these fundamental problems. And this is like, we need a shift in the elite opinion here, that the way that we're going to solve these problems is like grappling with what Medicare does through fee-for-service payment, precisely through Part A, through Part B, Part D. This is how we're going to just bend the cost curve.
I had a flash of the pattern matching that I'm recognizing here, which was when proponents for Medicare for All felt that any effort to improve that the ACA was terrible because it wasn't Medicare for All, and that any attempt to reform the system in doing things that are actually maybe politically feasible is somehow the enemy here, and it's not. I think the attention that you're putting towards kind of shooting down the one the one program that actually seems to be bending the cost curve significantly and in an under-recognized way. I think you raised I think the assertion that the benchmarks are not counterfactuals. And I agree with you, benchmarks are not counterfactual. And in fact, the benchmarks are structurally designed and are undercounting the earned shared savings are substantially lower structurally. If you just think about if an ACO reduces the cost in their region, they're in the region. So that structurally takes away savings from being recognized. If ACOs get rebaselined, the savings that they have accumulated over the course of the past 3 years, 4 years, 5 years, the majority of those savings are taken away in the benchmark. If ACOs reduce cost of care in traditional Medicare, and that reduces payments to Medicare Advantage plans, that is not calculated anywhere in those benchmark calculations. So systematically, we are showing savings, growing savings, billions of dollars of savings, and it is undercounted because the benchmarks are designed to go down. And you mentioned prospective trend, where a third of ACO's benchmarks now are based on a 4 or 5% presumed trend, whereas real trend was 9%. So those are all factors that have massively, I think, reduced the true credit that ACOs should be getting. And I would just wish that if you want to have allies in addressing whether it's consolidation or whether it's the mispricing or whether it's fraud, waste, and abuse, like actually ACOs can be allies who are close to the patient. They can do what insurance companies and CMS cannot do, which is to actually know the patient. We're the patient's primary care doc, so we know if the patient actually needs that skin substitute. And I would say,
Oh,
like, why are we giving up that the people closest to the patient's care and their clinical needs, why do you want their incentives not to be aligned with societal incentives?
all right. So I think that this has been a great conversation, a lively debate. I appreciate you both taking part in it. I want to end with a slightly different question for each of you. So first, I want to talk a little bit about political feasibility. And Andy, I'd love for you to sort of talk about what you think is the most politically feasible possible next step in the vision that you've laid out related to reforming payments. Um, and then Farzad, I would love to hear from you in a slightly different question about, if we take it for a given that primary care ACOs, as you've laid out, have been successful, there's a large landscape beyond the world of primary care that don't fall under that umbrella, and how you think about next steps in that setting. So Andy, you first, you have 4 minutes.
Yeah, great. So I think that, the political feasibility from some of the agenda that I laid out comes from the fact that it more or less involves Medicare managing control over the fee schedule that it's already, under its supervision and needs some additional authority from Congress. But it's basically managing Part A, Part B, Part D in different ways. And so, we're not talking about nationalizing physicians. We're not talking about, forcing everyone into group model HMOs or something like that. It's basically saying, like, let's just manage the fee schedule that we currently have. And so from that perspective, I think operationally, it's quite feasible. I think, like, a huge obstacle has to do with elite opinion and this kind of, like, this view in the field that you heard from Farzad, that risk taking and risk contracts are kind of the only way forward. And, this is just what we have to do. And, it's kind of like a, 4 legs good, two legs bad kind of situation you just hear over and over again. I think we need to come to grips with the fact that this isn't working, and that, it's not saving money. And even if you want to say, like, the money, if you take estimates at face value, it's an absolute drop in the bucket compared to our larger savings, like, and larger spending in the country. So I think, like, coming to grips with that fact that, this isn't working and it's not going to work is essential for, like, moving to building the political will to address, like, this affordability crisis. And I will admit that there's special interests that are definitely averse to fixing the fee schedule. You have specialists who would be paid less. You have hospitals who some would be paid less, pharmaceutical companies. You have like middlemen who are involved in all the VBP stuff who would get less. And so, but I think that has to be like, we just need to come to grips with like what they've been kind of the kind of theory of VBP, the win-win, everyone's going to win, everyone's going to be better off. It's just not happening, and it's not going to work. And so I think the sooner that we face these trade-offs and come to grips with what actually needs to be done to address spend growth, the better. Like if we say like, oh, we need another 15 years to study VBP and figure out like what's working and what's not, like we will just waste another 15 years.
Okay, thanks.
I, I, I have not heard through this whole discussion an answer to how do we, if is fee for, can you imagine a world where just setting the right price, assuming that you could even do it, if it creates incentives to keep people from having heart failure, kidney failure, heart attacks, strokes, nothing in paying the right amount for a stroke creates incentives to prevent strokes. And we all know there is so much unnecessary suffering that's happening because we do not fund primary care. We do not fund prevention. And this is an example of a program that demonstrably has created those incentives where we are doing more. It's not everything. Yes, I cannot control specialist costs, but I can reduce hospitalizations. I can't control the DRG payments to the hospital, but I can make sure there are fewer of them, and we are. And I think that fundamentally to me speaks to not just looking at this as how do we cut costs. There's lots of ways to cut costs. You can give patients less. You can do more UM. You can do more denials, which I'm hearing you say like we should do more of those things. You can pay doctors less. You can reduce costs absolutely doing those things. And there are some times when you absolutely should be doing those things. But what about the fundamental incentives to not have people get sick, not have people have strokes? What is the answer to that if it's not aligning long-term incentives for primary care with total cost of care?
Yeah, can I respond to that, Rachel? I mean, what I'd say is that we've like fixated on these ideas around improving health through healthcare payment. Like that's the mechanism that we're going to enhance health in our country. I mean, I've heard it several times through Farzad, and we all know like how weak that literature is in general about how healthcare and how healthcare incentives affect quality and outcomes. I mean, there's decades of research on pay for performance, aligning financial incentives. What does it actually do? What does it accomplish? Maybe it gets providers to document more. Maybe it gets people to, perform marginally better on some process measures. But the evidence that financial incentives actually improve health and make people better off is incredibly weak. And it's like, even if you can
You keep saying this doesn't work. What does work, Andy? You keep saying this doesn't work. What is your
Yeah.
solution to
No,
to more prevention?
I think the solution is to decouple spending growth with ideas about what makes people healthy and try to think of rational, reasonable ways to reduce spending growth in a way that either encourages cost-effective care or is frankly cost neutral. And the agenda to improve people's welfare and health doesn't happen through the payment system.
How do you control people's blood pressure? How do you create incentives for the incentives
You
and
don't.
resources and
You
time
don't.
to improve? Okay, so you're not going to improve blood pressure control
I'm
which
not
is
going to
the
do it through the
number one
payment
thing.
system. Yeah.
All
You're not
right.
going to
Well,
do it.
I think we have a lot left to debate. Unfortunately, we are at the top of the hour. As I said, thank you guys both for joining me for this debate. It's a tough problem to solve, and there's a lot of work to be done. But thank you both for the work that you are doing in this area. I hope that the audience can enjoy today's talk and will be available to join us next time. Our next event is on financing long-term care. Another one of my favorite topics. It will take place on December 12th by Zoom, and we hope to see you there. Thanks, everyone.